I will also just take a moment to do a shout out back to Leslie, who, although she has retired as a GP and continues to be a syncope champion and to teach as an associate professor, does more than full-time work running and supporting the charity. And she doesn't yet have an OBE, but she should, and we should launch that campaign, I would say. But you could argue we've got one of the most important talks now. From the patient perspective, Anita Kiernan was previously a community nurse in Salford before your health deteriorated. You still managed to work within NHS. And I've heard you speak before. It's always a powerful and thought-provoking experience. So thank you so much for being here and doing this for us all.
Thank you for having me. Yes, that was a really lovely introduction. Thank you. Yeah, I'm Anita Kiernan, volunteer with POTS UK. It's lovely to be invited here to talk to you today. I've been asked to talk about the impact of POTS and adjustments for work, just on the basis of my experiences as a patient and an employee. So it's probably helpful to give you a little bit of context about my background and my journey with POTS. I had a healthy childhood, normal, active teenage years, involved in lots of sports, quite fit and active. But from around the age of 16, I started to develop lots of symptoms, mostly frequent unexplained collapses, lots of lightheaded spells, increasing exercise intolerance. So I had a number of different investigations over the years. Started off being advised it was probably anxiety, teenage hormones, kind of usual. I did receive a postural hypertension diagnosis in 1997 when I was at university in Newcastle. And later, when I was doing my nurse training in Liverpool, I was advised I had benign sinus tachycardia in 2002. But nonetheless, regardless of the diagnoses, I had continuing symptoms which were starting to affect my nurse training, and my early district nursing career is becoming quite tricky, as well as obviously the personal impact on my normal social life. Over time, it became more of an increasing disability rather than just a selection of symptoms. The impact became much more severe. So the severity of each of those spells became much worse. 20 to 30 times a day, every time I kind of stood up or was standing for a period of time, I would get those really strong lightheaded episodes, postural hypertension type episodes, but also the sort of fainty symptoms, as it was referred to earlier, including collapses to the floor. Very, very rarely lost consciousness. I could always hear what was going on, but I just couldn't always respond. Standing tolerance was much reduced, less than a minute or two before I'd get those kind of severe chest pain symptoms, lots of tachycardia, breathlessness. And then I started to get new cough syncope symptoms as well, which brought in a whole new raft of difficulties because obviously it's quite unpredictable when you're going to cough or sneeze, and I was nearly passing out on those occasions. Also things like looking up, stretching, yawning, all sorts of seemingly random at the time symptoms. And then the increasing heat and exercise intolerance. So particularly moving from a cold environment to a hot environment, become very, very lightheaded and feeling quite faint and needing to sit down to feel better. Lots of gut issues, brain fog, fatigue, lots of the symptoms that you've already heard about in the previous presentations. I really identified with most of those. So I received the actual provisional POTS diagnosis was in October 2007, at which point, unfortunately, I lost my driving license because of the unpredictability of those symptoms at the time. There was not a clear pathway for treatment, and there was no medical professional that could tell me at the time how I could get better. So unfortunately, I lost my license at that point. And I had 5 months off work because of the level of disability. And obviously, as a nurse, I was needing some support myself and unable to care for people. But successfully redeployed by February 2008, which was a difficult time, but I did move into an NHS commissioning role and I had some reasonable adjustments to help me with that. The actual POTS diagnosis was confirmed just down the road at the National Hospital for Neurology after the birth of my baby. And I had that diagnosis of POTS and reflex syncope and joint hypermobility syndrome. So there followed a treatment plan. From 2009 onwards, I had all the treatments that we've just heard described by Leslie earlier. The non-pharmacological measures with compression hosiery, low sodium, the extra salt in the diet, obviously lots of liquids, and lifestyle changes, so no alcohol, lots of early nights, pacing, and so on. And then some treatments of fludrocortisone, which I had had previously, but had greater effect when we had the slow sodium and the midodrine added in. And then over some years later, I was able to try the octreotide injections, which were a game changer for me in combination with an exercise rehabilitation program that I was really fortunate to access at the time under a local cardiac rehab team up in Salford. I had some energy conservation support and fatigue management, which as an occupational therapist really helped me with that, and some cognitive behavioural therapy, just to help learn to manage living with this condition, which was quite disabling and quite isolating at the time. So I was discharged back to my GP in just a couple of years ago, because I've been able to reduce quite a lot of those medications over the last 3 or 4 years, remaining stable at the moment just on midodrine and slow sodium. Happily, my driving licence was reapproved in 2018 because of the stability of all my symptoms, and the severity is much reduced. And in the last couple of years, there's been probably a really positive impact for me of the increase in home working, which has really helped me to manage my fatigue. So my episodes now are much more likely to be kind of weekly, sort of head rush type symptoms, but more monthly in terms of actual collapses or near collapse. So yeah, given I've had this since I was 16 and I'm now in my mid-40s, I've not felt this well in about 20 years. So to answer the question around whether patients can get better, I hope that is a little bit of a good news story. It's not gone away. I live with this and manage it. It doesn't dictate my life in the way that it used to. So in the context of that big change over such a long period of time, I thought it's quite helpful to talk about the impact on my work, because I think we can all agree that working and having meaningful employment and activity is a hugely important part of for all of us and any patient's care plan, particularly those with long-term conditions. And understanding my condition, when I finally got that diagnosis and really understood what was going on, it really helped me to understand what I could and couldn't do and have that focus on the things that I could still do. So actually, nursing for me at that time became impossible, but I was able to accept that better when I really understood my condition, and was able to use my skills in a different way and make that life-changing decision, which was really sad. But I was able to do that and to try and move forward. But I really want to stress that not everyone will be able to make such decisions, whether it's financial or personal reasons, or they're not there on that journey. So I'm absolutely not saying that you have to change your careers with a POTS diagnosis, but for me, it's just my personal story and where I was at. It's actually helped me moving forward to have not been standing in a job where I had to stand up all day or get up and down all day. So just making that change sort of has enabled me to help myself get better. It's also important to recognise that POTS is a syndrome. As we've heard, there's lots of different presentations with sort of predominant symptoms from, and because of that, people will be able to continue successfully in their own jobs. A lot of people will not need to leave work, but equally, some people have such severe symptoms that they cannot work, and I absolutely recognise that and acknowledge that as well. So we're all on quite a different journey, but I just want to share some of the things that have helped me in terms of work along the way. Including that good clinical support and the effective aftercare. So having more POTS awareness amongst clinicians means it's more likely to be recognised early, as we've seen, and that might reduce deteriorations, as Dr. Cole just mentioned earlier. And that in turn might mean we have less time off work, and the spiral of being off work and the effect on mental health and self-esteem may be reduced. And it allows that person-centred rehabilitation and support, not just the medical treatment with the different drugs that are available, but that more holistic way of supporting patients. It didn't offer me a cure, having that diagnosis, but it did help me to get the access that I needed as an individual. So some examples of that, occupational health could provide some advice to my employer, because they could say what was wrong and what was likely that I could or couldn't do, which really supported me with that redeployment at that really difficult time in my life. And it's helped me since then in recruitment and promotions. I could make an access to work application for disability employment support. And for me, this involved getting some taxis to and from work for a number of years. And that was because the severity of my symptoms, which happened when I'd be standing in a queue. So obviously queuing for a bus or public transport was really difficult. Standing on the public transport if you can't guarantee a seat. Managing the temperature change from the cold to a hot bus, for example, was just really impossible when I was so unwell. And the frequency of collapses that I was having, I was very vulnerable and felt very unsafe being by myself because I was just constantly collapsing or feeling very unwell. So once I was in work and I was able to get to work, that was the first step. But then I worked in partnership with my GP, with occupational health and my consultant, so that I could document my needs and how these could be met with reasonable adjustments back when I was redeployed in 2008. So some of these are really simple examples, but I thought I'd share them in case it's useful. The things that really helped me was when occupational health just stipulated that I needed an office chair with head and arm support for when I felt a bit faint. I could sit down and feel safe. And it's just a small thing, but makes such a difference. Just like having a seat here today, just makes that difference for me to be able to be here and do this. Having a stool to raise my legs under the desk, just to help with that circulation. And placing a seat next to photocopiers back in the days when we did a lot more paper-based things. So I could sit down and have to stand for long periods of time just doing some of the tasks I was doing back then. Having a desktop printer for the same reason, didn't have to keep getting up and down and sort of triggering all these spells, albeit moving around is important, not constantly getting up and down for me. Having a desk fan, sitting somewhere cool to keep temperature control. Being able to use a lift at work for safety reasons, rather than stairs, because at that point in my life, climbing stairs, I would often have to crawl upstairs, to be honest, rather than climb them. Working from home, once we started to get laptops, so I could work from home a day a week, which really helped with the fatigue management. And as I've said, increased working from home has really helped in recent years. And having some flexibility with work hours, so if I needed short breaks for eating or drinking, or if obviously if I'd had a bit of an episode, I could make up time later and that wouldn't be sort of looked down upon. So another thing I did, I chose to write a care plan. Probably, I guess with my nursing background, it came a little bit more naturally to me to want to do this, but there's three main reasons. And it was to try and avoid undue concern or anxiety in other people who would witness those kind of spells and not know what to do or feel quite panicked if I was on the floor or feeling unwell. Or eyes all around the head, hanging onto furniture, you know, clutching at the chest, feeling like I'm out of breath. And people would worry, and that's natural. And then I didn't want people to panic. So describing what actions would help me if people did want to help was sort of a way that they knew what to do then. So just bringing me a large glass of water, having a chair nearby if I was on the floor so I could get up really slowly rather than in one big move. Those kind of things, not asking me lots of questions straight away because people are keen to help, but actually I can't think straight, I can't get the words out, I have the brain fog and my words just don't always come out. So if they know what to do, that really takes the anxiety away for me, which is the third point. It enabled swifter recovery because I wasn't worried, everybody else was worried, and it just helped me recover much more quickly. Because there's nothing more disconcerting than hearing people saying, should we call an ambulance? And in your head you're thinking, please don't call an ambulance, I'm fine, but you can't get the words out. So many workplaces do offer things called wellbeing action plans, or they're sometimes called workplace wellbeing toolkits, and it's always worth advising your patients to look for those things, because they can just be documents that help people do a similar thing, to document what your needs are that would help you to maximize your well-being in the workplace, and how, and you know, obviously the result of that is greater productivity, but it also enables that conversation with line managers, which can be quite sensitive and quite difficult at times. So I've obviously had really good experience myself within the NHS. I've been really lucky. But I do know from both the work I do with POTS UK with the volunteers and the peer support groups and the staff disability groups that I'm part of, that there are often quite a lot of barriers to working well. And some of these are having ineffective or inconsistent implementation of the Equality Act, corporate policies or values, so where organisations say that they're all about compassion and respect, but it's not felt on the ground by staff. Having a lack of individualised support, by which I mean just listening to staff. I think that's a really, really important point, that the person is often the expert in their own condition. And so, you know, line managers need to not make judgments about what they think is the right thing to do, but actually talk to the person who's got the condition and try and form an understanding rather than make a judgment. So there's often reduced employment or recruitment opportunities for people with disabilities. And sometimes that's organisational expectations, that kind of sense of having to be seen to be doing, being present in the office, or that you need to travel across sites. And hopefully some of those barriers are starting to reduce now as a result of a lot of the kind of home working and different ways of working during the pandemic. And sometimes it's the impact of pain and fatigue and medication side effects, all that kind of uncontrolled or variable symptoms can really impact on people's career ambitions and confidence. And so it's important to acknowledge that and really support staff. Sometimes there's been problems with previously agreed adjustments not being honoured, so that's where occupational health can really help, but also line managers themselves. So when there's been an organisational restructure, it can be really anxiety provoking, thinking, am I going to get that same support if my manager changes? And having inadequate support from GPs and clinicians, and we know that everybody is extremely busy, but sometimes those kind of delays with sending referrals or the reports that employers need, and the lack of joined up care pathways can really impact on people getting back to work, which is obviously what we all would like to do ideally. So for me, the impact of reasonable adjustments and having reasonable line managers has enabled me to continue NHS employment for the last 20 years, which is I'm really proud to have done. And it's enabled me to gain promotions, and despite the fact that I was collapsing frequently throughout the day for probably a decade of that time, and I had minimal sick time, and that's because of the support I was given in the workplace. And my manager strongly believes that if health and disability needs are supported, then compassionately and with reasonable adjustments, then that individual work performance will follow, and you will allow staff to thrive, and in spite of their disabilities. So you feel empowered to do well, and to the focus is on the work outcomes and not on the condition, whether it's POTS or long COVID or any of the conditions we've heard about today. So in his words, my line manager has said, my responsibility is to help create an environment within which you can reach your potential. That does not mean an environment which assumes you to be less capable or productive than anyone else, but which is necessarily individualized. So employees need managers who will listen, take action, and lead by example. And the supportive line manager has been a necessity to me. Reasonable adjustments goes way beyond just having a policy or writing things down, but it's about really supporting your staff and making sure things happen. And many clinicians here today will also be line managers or have teams. You'll have colleagues who've got long COVID, they may have POTS, and you can advocate for them to really help them and make some adjustments and help maintain work where it's possible, and improve that experience and keep them well. And so that's my question to you, is if you are a manager, have you discussed these things with your staff who have long-term conditions or disabilities? Often the things that people need are minor changes. As I mentioned earlier, some of those examples, and they can have minimal or little impact on others, just changes in ways of working or environmental changes in the office space. And those kind of steps can be really life-changing for the employee, who will feel valued and included and respected. And the impact of this on your mental health and self-esteem, it just can't be underestimated. So as a clinician, are you supporting your patients to be able to express their needs and to gain that workplace support that they need? So lastly, just in summary, how GPs and clinicians can all help. Firstly, it's having the awareness of POTS. There's a great little summary on the POTS UK website. It's a GP guide. It's just really easy to share amongst everyone so that people are more aware of POTS, which is the first step in getting that early diagnosis. Because I did read that it takes an average of 7 years to get a diagnosis, a lot more in many people's cases. And having that awareness both for POTS and the links with all these other conditions, Ehlers-Danlos, chronic fatigue syndrome, mast cell, and autoimmune conditions, and of course long COVID. So picking it up early can really help to prevent that deterioration and that spiral. Effective liaison with employers, as I've mentioned before, and being a good employer yourself if you have staff with POTS. Stick with me on this journey. Now, this is a phrase that somebody said to me recently, and it really seemed to capture it for me, because I was a person with medically unexplained symptoms, as it was called, and these can now be explained. But syndromes and hidden disabilities are notoriously difficult, I guess, both for you as clinicians and obviously for patients to manage. But yes, stay with your patients. Words matter. Be really mindful of the impact of language with your patients who are really struggling through that journey. And of course, kindness costs nothing. A lot of those examples of adjustments didn't cost a thing, but the outcome for me personally was life-changing. So thank you to all of you clinicians who are helping people like me.
Thank you, Anita. Can I ask you if there was something that a healthcare professional, if they'd said to you earlier in your journey, would have made a real difference for you? So is there something that you feel that clinicians could very helpfully share earlier in the patient journey that could be helpful?
I think it's that sense of being believed that has been brought up earlier, because some of the things about the words that matter and that kind of thing, that seeing health professionals who expressly said to me, I'm not interested in your condition, or give you that sense that you might be just, you know, anxious or making it up somehow. So actually really believing those patients and making them feel heard, I think, is the first step. You can't resolve all the problems, but actually, yeah, just feeling like you've got somebody with you on that journey of understanding. So just try and show the patient that you believe them and that you hear them and that you're going to try and work with them to get to the bottom of these problems.
Lovely. We've got a question up the top. Oh, yes, hi. Lovely.
In terms of language, we have a lot of patients asking us about POTS being recognised as a disability. What's your experience of that in terms of the patients that you communicate with?
Yeah, I think some people definitely have problems of having it recognised. I think it's much easier now than it was. I think when I first got diagnosed, it wasn't really heard of, which I had all those different diagnoses along the way. But yeah, certainly some people struggle to get that recognition. But I think in line with a lot of syndromes where there's not always that much clarity, I think it can be hard because people don't understand it. They know what other certain particular conditions can be, but not always what this means. But there are obviously with having POTS UK and all the information that is now available, being able to signpost occupational health or doctors or line managers or whoever to this source of good information and support and the disability access, that really opens up the doors, I think, for patients nowadays to be able to say it's absolutely a condition, it's a definite thing. Does that answer the question?
That's right. Is there an actual official definition of that?
Is there official definition somewhere?
I'm not 100% sure what you mean in terms of what POTS is, or POTS as a disability. So I think the impact of POTS can be quite different for different people, can't it? So what was disabling for me was the lack of independence, I guess, because and the vulnerability of collapsing so frequently. But for others, they may suffer with constant nausea and those kind of symptoms. So how it comes out in different people might disable them in different ways from being able to do different things. So it's quite individual in that sense.
The question that I was kind of hinting at was in terms of disability benefit, we get a lot of patients asking us about that side of things. And patients who have said it's not classified as a disability, and I was wondering whether you'd ever come across that in terms of it.
No, I mean, maybe others are able to answer that as well, but I've because I've not had to apply for benefits, I've not gone through that, but I have come across people who peer support groups who have really struggled with things like PIP and applications, because trying to evidence that chronic and long-term impact on the activities of daily living is one of the sort of issues around having a disability, isn't it? And when you've got very variable conditions, that can be quite hard to quantify.
Okay, do you want to speak to some of that as well?
Yeah, so I'll give you some of that, and then I'll pass it to you, because I saw you were here, so it's great. So I'm a nurse, but I don't clinically work in POTS, but I'm a parent of somebody who's now 25 with POTS, and we've been part of that journey that's gone on, and accessing services and accessing whether it's ESA or PIP is, I wish I could swear. Well, I can swear, but I'm not going to, but it's been awful. It is an absolute nightmare because you are not believed, because you are young. You don't look, like with any invisible condition. So you really have to prove your case. And it is just, I know of so many people who stop, they go for that first round of PIP, and then they get told no, and they just don't have the energy because they're so unwell to get to the mandatory review and then get to a tribunal. And it's only by the time you get to the tribunal, then you finally get that, yes, we've been believed. And then you think, oh, and then I've got to do it all again in 3 years. And actually, I know some people who don't go back for the 3 years because they can't face that cycle again. It's bad enough feeling the way you feel without having to put it all down on paper and then stand up in front of, well, sit down in front of people and try and explain it. So I think anything that healthcare professionals can do to support, now I know it's very hard because you can't do that, but even just an understanding of how challenging it is. And another bit I'll say, so when you see patients and you think, oh yes, their symptoms have improved, writing something like symptoms have improved on a letter is great in some ways. And then it's absolutely awful when you need to use them. So it might be that your symptoms were 2 out of 10, that was your capacity, and now it's 3 out of 10. So they may have improved, but they are still pretty shocking. And so it really is, if you want to help these patients that are with quite complex disabilities, writing symptoms greatly improved really doesn't help us at all, if that's all right.
I also have some words of wisdom for our absent Oracle, Leslie, who knows all, who's just asked me to mention that, that as you intimated, Anita, whether a person meets the terms of the Disability Act depends on the individual, but there is a definition on the DWP website that can help guide with criteria with that.
Well, I'm a doctor who sits on tribunals for people who are appealing PIP decisions, employment support allowance decisions, and other related benefits. So I see people at the end of the journey when they've been turned down by the DWP. But a condition doesn't actually have to be recognised as a disability for you to apply for PIP or ESA. Supposedly, it's all about your level of functioning. The problem is the descriptors that are used and the way they are worded can be very difficult for people to score points on. And so that's where people fall down, and also the people that are assessing them by the DWP often don't recognise the conditions and aren't sympathetic. As a GP, I know we get a lot of requests to write letters, and it's often very difficult to know what to write. I think if you have a good knowledge of that patient and how it does affect their condition and how they are disabled by it, I think that's really good if you can write that down. I'm not advocating that you write for everybody necessarily, and it can be very difficult, but a letter where a GP may just say, this patient tells me, doesn't really hold much weight. But if you know that patient well and you're able to write something supportive, I would say please do.
Yeah, great advice, thank you.
I think.
Hello, I'm actually a paediatric physio, so I'm really keen to know about your slightly earlier journey. It was nice to hear that you said you got a sort of diagnosis around sort of 16, but actually the challenges that we find are you got into the workplace and there are those things in the workplace and there are, special educational needs supports out there, but actually getting it, if you haven't got that kind of diagnostic thing, and getting an EHCP, which is an educational healthcare plan, which supports a younger person to fundamentally get to where you got to be able to get a job and stay in academia is horrendous. It's like I've got one young person with hypermobility she's got Ehlers-Danlos. She managed to get an EHCP, and that is like mind-blowing. But there's so many other young people that I work with that can't even get like healthcare plans, which are that kind of real basic low level of just a nursing support within an academic environment, and the Senko vaguely getting involved Like, what's your kind of feelings and thoughts, and actually be intrigued from the Pot Society to get feedback from that?
I'm going to release Anita from that question because it's a very well timed question, because our next speaker is absolutely on topic with this. So we can revisit based on that, but we haven't given Anita.